Can you guys see it?
Yes.
All right. Okay. So today I'm going to talk about the recent additions to our therapeutic toolbox. As you know, we have a few new drugs for IBD out over the past year. So the purpose today is just discuss with what these new drugs are, how they work, and how we can practice prescribing them safely based on their risk benefits and their contraindications and how they work. So these three new drugs, at this point, ozanimod, which is an S1P modulator, was approved last year in May 2021 for moderate to severe UC. It's a small molecule drug, and was previously approved for multiple sclerosis, which is its other indication. The next one is upadacitinib, which was just approved this year in March 2022 for moderate to severe UC. It is a selective JAK1 inhibitor, also a small molecule drug, also an oral agent, previously approved for ankylosing spondylitis, atopic dermatitis, rheumatoid arthritis, and psoriatic arthritis. And then the third one that we have now in our arsenal is risankizumab, which is an IL-23 antagonist, just approved this year in June 2022 for moderate to severe UC. Now, this is also approved for psoriasis and psoriatic arthritis. Now, because we just have a few, like 20 minutes to talk, I don't want to go into detail of all the phase 3 drug trials. I do want to go over the relevant points in about the medications, their safety features, and their effectivity, and then basically the practical points of the discussion. But feel free to ask questions afterwards. First of all, let's talk about ozanimod, which is a small molecule drug. It is an S1P modulator, binds to S1P subtypes 1 and 5. It causes internalization of these receptors on the lymphocytes and hence prevents the migration of these lymphocytes to inflammatory sites. So that's its mechanism of action. The True North trial was the phase 3 trial for this drug, carried out from 2015 to 2020. It had two phases: the induction phase and the maintenance phase. The induction phase was still 10 weeks. It had two cohorts. One was a double blind with placebo versus ozanimod, a hydrochloride 1 milligram, and the second one was cohort 2, this open label ozanimod. And then we have remission data at 52 weeks. I'm mostly going to talk about remission data at 52 weeks, like maintenance phase, for all three drugs, just again for the interest of time. But over here you can see that for both cohorts in the induction phase at week 10, they had an 18.4% and 21% response, statistically significant, against placebo in induction, and again in the maintenance phase at 52 weeks, 37% for ozanimod and 18.5% for placebo. Now, they defined their primary endpoint as clinical remission, which is the adapted Mayo score, meaning the overall Mayo score without the physician's interpretation of disease severity. The clinical, it was defined as adapted Mayo score less than 2, with endoscopic appearance less than 1 and equal to or less than 1, and at least the stool frequency score equal to or less than 1. That has to be that too, or the clinical response was defined as change in the Mayo score from baseline by 2, or change from at 35%. So as you can see across the board over here, this is the 52-week data. Clinically, statistically significant response, like we just said, for clinical remission, but also response for, also statistically significant for clinical response, endoscopic improvement, maintenance of remission, and steroid-free remission. Now, in terms of safety, adverse events were just overall more in the both those ozanimod cohorts in induction as well as the maintenance. However, serious adverse events related to ozanimod and placebo were kind of arbitrary. None that show that basically ozanimod was responsible for serious adverse events. Overall, serious adverse events, yes, were more in the induction phase in the ozanimod cohorts. Adverse events leading to discontinuation were more in the induction phase for both the cohorts in of ozanimod. Infections were the more common ones, 46%, also in both induction and maintenance. Serious infection, more common in inductions. And then nasopharyngitis, which is, we are going to see a common theme, reported as one of the most common ones for both induction and maintenance. Herpes zoster, again,
Mm.
both for induction and maintenance. Hence, we're going to talk about that in a few minutes. Then common adverse events that are worth talking about: anemia noted in induction, headaches. Noted in both induction and maintenance, changes in ALT and GGT with an increase both in induction and maintenance. However, none qualifying as drug-induced liver injury and none leading to discontinuation of the drug. Bradycardia. So this is the one that we've all heard about. It was more common in the induction phase for both cohorts one and two. 2 and 3 as opposed to the zero in placebo. And then hypertension, again, in the induction group. Macular edema, although the incidence is low, but it was seen in both induction and maintenance. Patients with baseline macular edema were actually not included in the trial, so this is like something to note. Now, how do you prescribe ozanimod? We should have some baseline studies. Definitely check an EKG because of the risk of the bradyarrhythmias and AV conduction delays that we just talked about. An eye exam if they haven't had one, especially if they've had a history of uveitis or risk of uveitis, macular edema. Baseline labs, including liver function test, not recommended because it's not recommended in hepatic impairment given the review of the safety findings. And check shingles with the varicella zoster antibodies and vaccinate for shingles if they're negative. Safety for ozanimod has not been established in pregnancy, hence contraception is recommended at this time. Obviously, this data might change over time. Now, in terms of dosing, it has a recommended titrating dose. From day 1 to 4, it's 0.3 milligram orally daily. 5 to 7, it's 0.46, which is double the first 4 days, and then you double it again at day 8 and after to 0.92 milligram orally daily. This 0.92 is equivalent to the 1 milligram ozanimod hydrochloride that we saw in the True North trial data. So, and then moving on, the next one is upadacitinib, which is a selective JAK1 inhibitor, as opposed to tofacitinib, which is the other JAK inhibitor we are familiar with, which is a pan JAK inhibitor. Um, then, mechanistically speaking, uh, we can say that it's the JAK2 inhibition that leads to increase in platelets and hence should theoretically increase the thromboembolic events. So this is why it's important to note what the safety data showed, and this is one of the reasons that upadacitinib still has the black box warning that tofacitinib has, but it probably doesn't have the risk as much. Okay, moving on to the data about it. It had this was the it also had two inductions sub studies, the U achieve and U accomplish, labeled as UC1 UC2, and then UC3 was the maintenance sub study till 52 weeks. Both the induction sub studies were the same kind, 45 milligram dosing, and but there was two doses used in the maintenance study, 15 milligrams and 30 milligrams. So talking about this data, as you can see, this is just the maintenance data that I'm going to talk about for the maintenance phase, not the induction phase. You can see across the board that for both doses, 15 milligrams and 30 milligrams, there is a marked response in clinical remission. This is the same adapted Mayo score, which was the primary endpoint that we talked about for the ozanimod trial. Um, 42% for the 15 milligram dose, 52% for the 30 milligram dose, as opposed to 12% in placebo. And you can see very clearly endoscopic improvement, mucosal healing, steroid-free remission, and histologic and endoscopic mucosal improvement, all of them very clearly and statistically significantly better than the placebo. Um, then what about treatment of adverse events? Um, for overall adverse events, again, this is just not for the induction phase. This is for the maintenance phase adverse events for the two doses, 15 milligrams and 30 milligram doses. Um, not very, the overall adverse events, not markedly different from placebo, and even the ones that are different, the serious adverse events and the events leading to discontinuation, more in placebo as opposed to as opposed to upadacitinib, and no deaths. However, which were the kind of common adverse events? Again, we see nasopharyngitis for both doses 15 and 22, 15 and 30, as opposed to placebo. CPK elevation for both doses. None were significant for rhabdomyolysis, and none led to discontinuation of the drug. Um, but overall, as you can see over here, some patients in the placebo group, the worsening of UC and arthralgia, you can clearly argue was because of lack of treatment. Um, then adverse events of special interest, opportunistic infections seen in one case of 15 milligrams, and you can take that with a grain of salt because there were none in the 30 group. But herpes zoster, that's the one that's important. You can see in both doses it's markedly yeah, higher than the placebo group. One case of non-melanoma skin, two cases of non-melanoma skin cancer in the 30 milligram dose, um, and hepatic disorder. So again, more common in the upadacitinib group. Again, none leading to discontinuation of the drug and none qualifying as drug-induced liver injury, but two cases of venous thrombotic events in the 30 milligram group. Um, Now, as we should read the data, the both of these patients were very, very high risk, both inpatient, very sick patients who had developed these events. But again, we have to qualify this because of the risk factor for VTE, and then neutropenia. That's the other important one to remember. So how do we prescribe upadacitinib? There is going to be an induction phase as usual and a maintenance phase. In most adults, the induction phase is 8 weeks with a 40 milligram everyday dose. However, in patients who have renal dysfunction with GFR 15 to 30, or they are cirrhotics with child A or B, we lower that dose to 30. And also in adults who are on any CYP3A inhibitors like ketoconazole, clarithromycin, some even liver transplant patients. So they should be on a 30 milligram everyday dose. And then maintenance for all three groups is recommended to be 15 milligram every day starting from week 8. In some really severe refractory cases, we can consider a 30 milligram daily dose to keep them in remission. Baseline, we should check CBC like we talked about, avoid in patients with of neutropenia and anemia. Check baseline renal function. If GFR is less than 15, it's not recommended. For patients with liver cirrhosis, child C score, it's not recommended. We should check a baseline lipid profile as well. And then considering that the interactions, if patients are on CYP3A4 inhibitors, and even if they have hepatic or renal impairment, then the drug is not recommended. Safety is not, again, established during pregnancy, so contraception is recommended. Last one, risankizumab. This is an overview of biologics that we have currently approved for Crohn's disease. Moving from the right side, we have our anti-integrins. You can see vedolizumab and natalizumab. Then in the middle, we have our anti-TNFs, infliximab and adalimumab as first line, and then certolizumab and golimumab. And then coming to the left, you can see we have ustekinumab, which you're familiar with, the P40 sub, which is an IL-23 1223 antagonist of the P40 subunit, and then risankizumab is an IL-23 antagonist of the P19 subunit, which is our new drug. So for the Fortified trial week 52 data, there were two co-primary endpoints. There was a US protocol in which the primary endpoint was the Crohn's disease activity index. And then there was a non-US protocol, which had stool frequency and abdominal pain scores as the measure. You can see here that for the US protocol, both doses, there were two doses used. I should have said before. Risankizumab had 180 milligrams and a 360 milligram dose for the maintenance phase. Now, for the US protocol, both the 180 and the 360 milligram dose were statistically significant with from the for the primary endpoint. However, for the non-US protocol, the 180 milligram dose was not. However, both were statistically significant in measuring endoscopic response in both the US and non-US protocol. This is a very important figure, I find, because they split this response into patients who had had previous biofailure to those without previous biofailure. And this is encouraging to note here that many patients who'd had previous biofailure still had a statistically significant response to risankizumab. And obviously, patients without previous biofailure did well, but so did patients with previous biofailure, which is encouraging to note from our perspective. Now, in terms of adverse events, uh, you're going to see from the table the adverse events across the board, including serious and severe adverse effects, were similar for both doses as compared to placebo. Again, including the adverse events leading to discontinuation of the drug, they're kind of similar. So there's no clear kind of risankizumab induced adverse events here that I should talk about. But moving on to the frequent adverse events again, you can see that there was some evidence of nasopharyngitis, but in this group, we're seeing that with the placebo group as well. So again, we could probably take that with a grain of salt, but also to remember. Now, in this data, they don't talk about changes in liver function as a concern, but there is on the package insert, there is a warning because there was at least one case of documented drug-induced liver injury for which they had to stop the medication. I think the reason they may not have it listed clearly here is because the investigator did not think it was because of the drug, which is why when I'm going to come to the safety here and prescription information, for precautions, we need to check baseline labs, including liver enzymes and bilirubin, and it's recommended to continue following, which I think most of us do for most of our biologics anyway. Then for the induction period, it's like ustekinumab, the induction is infusion, and then the maintenance is subcutaneous. For induction, there is a 600 milligram IV dose at week 0, 4, and 6, 0, 4, and 8, sorry. And then maintenance is a 360 milligram dose subcutaneously every 8 weeks, starting at 12 weeks. And there, if you guys must have seen this already, but the current approved version comes with this autobody injector, which the patient can place on their body, and there is a button that they can press, and the autobody injector continues to inject for 5 minutes subcutaneously, their dose subcutaneously. Now, in summary, we have ozanimod, which is an S1P modulator, approved for moderate to severe UC. It's a small molecule drug with once daily oral dosing. Check baseline EKG, eye exams, and liver function before you start. Check for varicella zoster antibodies and vaccinate if negative. Upadacitinib, selective JAK1 inhibitors, approved for moderate to severe UC, small molecule drug with once daily oral dosing. Check and monitor your CBC, your renal function, liver function, and lipid profile. Again, check for varicella zoster antibodies and vaccinate if negative. And then we have risankizumab, an IL-23 antagonist. It's approved for moderate to severe UC. It has IV loading doses week 0, 4, and 8, followed by maintenance dosing every 8 maintenance doses after that, and then check baseline liver function and bilirubin monitor for changes in lipid profile. And I thank you for listening. I'm gonna stop sharing my screen at this point, so everybody can ask questions. I hope I didn't go over my time.
No, you're good. Did anyone have any questions?
So I do have a question. I don't
Yes.
think there's any guidelines about how often to check liver function test for UPA. How often are most people doing it? I typically check every 3 months. I've not really had any issues with
I didn't
transaminases.
find guidelines. I mean, when I looked in the trial data, they specifically didn't say that, but I'm pretty sure that we are going to have this soon. And like we know, the reason these drugs were not included in the AGA guidelines is because the AGA guidelines came out before these 3 drugs came out. I agree with you. I mean, I think we are all used to just at least checking at least every 3 months, if not more.
Yeah.
Especially the ones who have baseline derangement. But I didn't find a clear consensus on like exact intervals recommended to check.
So I'm super excited about risankizumab. I started, I think, my fourth or fifth patient on it today. I haven't had the chance to start anybody on the on-body injector yet, but the infusions have seemed to be going really well. If anybody out there has any questions about rolling it out, let me know, because I think every center has experienced a lot of, barriers because the J code hasn't been developed yet for risankizumab. And so a lot of insurance companies are saying they're not even willing to authorize it till January 1st when, the window reopens. And so what we've been having to do is use emergency authorization and actually contacting AbbVie to help them use the bridge program to get patients on get the induction dosing. So if
Yeah,
anyone
I'm the
has any
same
questions,
with
let me
you. I
know.
think the ones that I've started are still in the induction phase for the same reason that we had a delay. So, and I don't think I have anybody yet who's on the phase where they're on maintenance with the subcutaneous. They're all in induction phase right now.
Yeah, I have a brief question. So RISA is anti-IL-23, right? So if you have a patient that fails Stelara, for example, and had a primary non-response, would you consider that a failure in class? And
No,
would
no,
you even consider RISA?
no, yeah, that's actually a great question. So in the data that they show, the trial data, some patients who failed Stelara still responded to RISA.
Nice.
Yeah, right. I know, because it's like it's binding to the other subunit. I don't have a great explanation why, but they actually demonstrated that. So because I guess it's a common question, but some patients did. Yeah.
Nice. Thank you. That's great.
So when I talked to the clinical trial people, what they said was that what they're thinking is that IL-12 actually has a reverse response where it actually can upregulate IL-23. So what they're thinking is that by not blocking IL-12 anymore, it doesn't act as a barrier to the antagonism of IL-23. And in the original trials for RISA, it showed they had 20% of patients had failed Stelara. So a pretty good proportion. So I would say if my patients have failed USTA already, I still will put them on RISA.
And another brief question. I mean, this is probably too soon to say, but no data on post-operative efficacy for RISA, like for recurrence.
For post-operative?
Yes, like
I don't
yeah.
think they included that. Not that I may have missed it, but not that I have seen. I don't think they included that specifically.
Got it. Thank you.
I think the one thing I'm, watching for is when they're going to come out with data, including trough levels, what we would shoot
Exactly.
for.
Yes, exactly. Yeah.
I don't know what that would be yet. So, but I'm assuming that eventually they'll want us to go to Q4, for refractory patients. But we're not there yet. And so, yeah, I would say I've been using all three of these medications. I've had a lot of success with both UPA and risankizumab. Risankizumab lately, now that we've gotten a lot of patients on the induction, it's been going really well. And if you need any help with the bridge program, we have a lot of information on that for you. Same thing with UPA, they have, a really nice bridge program as well as ozanimod. All these drugs, obviously that's, a huge thing that the industry provides for us is a bridge program to get all these patients started, even if they're on, a like Medicare or Medicaid, where initially it's hard to get them approved, but they'll often give free drug for at least the first 2 years, even if a patient isn't approved. So always make sure you reach out to these drug companies because oftentimes you'll get at least a 2-year leeway. Everybody out there, have you had any issues with getting risankizumab induction therapy at your infusion centers or outlying infusion centers?
I've only had one patient. He's still in the induction phase as well. We had some difficulty in the beginning, but we used that bridge program with AbbVie, which was pretty helpful. Correct me if I'm wrong, but I believe the AbbVie rep had told me that we didn't need to check drug levels
No, I think right now we don't know yet what the drug levels are going to be.
Okay.
So I'd like to wait for that. I mean, eventually it will come out. I think the same thing with Stelara when we were first using it, it wasn't clear whether or not to check for trough levels.
Yeah, I think, yeah, I agree. I think it's gonna take time and answer all those questions like, does it work in combination? Was safety for malignant infection and
Exactly.
post-operative, is like specific settings. I think all those questions that typically come after we have some real world data, I guess.
Yeah, it's like all our biologics, like all the biologics that have preceded it in the past. We've learned things over time.
And for sake of attendance, we have a few